You're welcome.
Thank you.
Osafo.
Boss, good afternoon.
Akwaba.
That's it. Thank you. Boss of Moreno.
You've moved?
Yes.
Oh. All right. Thanks for joining me this afternoon. And we're talking about medicine that focuses on the healthcare, health issues of the elderly. Am I right?
Concerned with problems of the elderly,
Okay.
whereby we are looking at how to prevent them, how to treat them, should be done at the treatment or the tail end.
Okay.
Rehabilitative services as well, and how to include them in society, inclusiveness.
Okay. Right. To identify them, prevent them. You know, we tend to think that as you age, and especially when you get into that age, you should, you must, you will, and manage them from a preventive perspective. Of course, we want to be able to identify persons in this category. Dr. Nimopari, do you want to add anything to that?
I think pretty much everything has been said. I think, like he said earlier on, the other thing is that it's in terms of being biological or medical. You want to go ahead and look at factors like their physical strength, dependently or dependent on other people in their household. And you're also looking at things like their cognition. So as they age, they have they are depressed. So trying to put all of this together gives them physical, functional, and then their cognitive needs. So that's what I'll add to it.
All right. A special cadre of medical professionals that deal with these issues.
You do have the training for geriatrics in Ghana.
Right.
That's being run by the Ghana College of Physicians and Surgeons, headed by Lenusia Ahilija.
Right.
So it's something that is available in Ghana.
We are
and there
building
are many,
the capacity.
Yes, and there are many other residents in training.
Okay.
So you know that there's a difference when people are identified in a geriatric clinic as opposed to a general OPD service.
Okay.
But recent outcomes, and these outcomes were measured in the matrix of the fact that they have less hospitalization than people who did not. To add to that one, there's also improved satisfaction from the patients themselves, because it's a more comprehensive approach. Typically, from they come and they know that they are not just going to receive a prescription.
Shop.
Exactly.
Instead of the typical to seek healthcare.
Yes. And that is the nail right on the head, because the other advantage that has been documented is that it improves coordination of care from one doctor to the other. The kind of care is coordinated between this primary, maybe seeking maybe care for hypertension, the condition here, and then going for bone pain here, and going for came across, says that generally the cost of care is reduced approximately by 20% when you have.
If you just joined us, 17 minutes past your Joy 99.7 FM, Ultimate Health, your ultimate guide to healthy living with me, Nortey by nature. These things over the years, and you know I've mentioned that Ultimate Health last week was 20 years. The more the descriptions and the classifications, if you are in the target group yet to be defined by age, right? Accommodation made for you, right? That makes it easier for you as compared to the average Ghanaian going to age group. And they make it 7997. Shortly, I will activate the phone lines. I'm in the studio with Dr. Ernest Nimopari and Dr. particularly, emphatically, in Ghana. All right? Because sometimes you read stuff outside and within this geriatric space or span, who
falls within that bracket.
60 and above.
60 and above.
Okay.
Yeah, there are no... It varies. Also, even within this classification, there is a social one, which sort of borders more to when you are going to expectancy of that population, the available services to take care of the elderly and all that. So generally, 60.
Your auntie, and especially if they are visiting the health. If we look at Ghana, I tend to know and believe, all right? And am I wrong?
Yes, it's true. Men tend to die before women in our part of the world. Making behavior of men tend to be poorer than that of women. Women like going to the hospital.
Just say it point blank, right? So, gentlemen listening to me, you are likely to die earlier. What? Healthcare?
Healthcare.
To report anything any discomfort and so on and so forth. And
the female hormones tend to be protective in some situations, especially more or higher advantage
Okay.
as to living longer. Women stress men, but then that's what happens.
Right. They're killing us. Crazy. Right.
Yeah.
But okay. Yeah. Right. So in terms of demographics, we'll see more women in this category. Present in this 60 and above category would tend to present with
area.
right.
Probably it's a good area to look into to find, despite the trend, the apparent disparity between both gender, there is hovered around 3.5, and in 2022 it came to 3.6, albeit marginal. It's a good indication that
Marginally,
perhaps
we are living long.
everything put in place, I think we're on a good track, and
Okay.
we need to continue.
Great start. 24 minutes past the hour. 2 on Joy 99.7 FM. We're talking about geriatrics to add, share experiences. WhatsApp is 055 11 11 997. I do believe just audio coverage. YouTube is down. Shortly, I will activate the phone line so that you can ask the questions yourself. So, picture of those we're looking at. Okay. I said also that many seem to hold the you must have challenges, right? There will be a deterioration in your health status. By and large, to talk of, well, I don't know whether to rank them or say top 5 or whatever. What are the common things we're seeing the elderly present with in Ghana?
Okay, so this area is well documented. Themselves not a disease entities, but they tend to be a presentation. So we describe them as geriatric syndromes.
Okay.
So in this group of conditions are not necessarily a disease
Right.
where they are confronted with issues of memory loss.
Okay.
Sometimes they can have not being able to name appetite,
Okay.
or they are losing teeth,
Right.
or they've lost sense of smell. So all of these are very common things in that specifics, and they have their own modifications when it comes to their treatment, because in as much as you want to is not able to eat enough, you have to tweak their diet and tweak their medication.
Okay.
Just over this week I had a patient like that who was almost in loss of consciousness and was found in his office and was rushed in. When I looked at his profile, I realized that he was a patient with
almost
what had happened. So together with the team on duty, he was resuscitated with glucose and everything. It happened that maybe, having said that they are geriatric syndrome, it doesn't necessarily preclude them from other medical conditions. But these
Right.
are
We're saying these are more likely to be
Yes.
seen in this age group. You're more likely to fall. You're more likely to have these memory things, right, as they present, and be, I guess, more vigilant for them in this age. Sleep challenges in this group. Would that be part of the syndromic, but sleep challenges that are significant enough to affect?
times people will just ignore and say, oh really, you can't sleep, it's not a big deal, then you are not sick. But for an elderly person, I mean, for anybody who can't sleep, it may be things, and like I said, it doesn't have to be a diagnosis, because if the person presents with inability to sleep consistently, there's
And of course, they are clearly diagnosable, identified, or classified.
Preponderance of cardiovascular disease as a result of accumulation of risk factors from the kind of food we eat, our habit of ignoring regular checks and things cumulates in these things. Also,
Keep up with my listeners. When we
Sure.
say cardiovascular,
Yeah.
of course, amongst us, you quickly listing stroke and a few other things. Then they know where we're going and the cluster of things we're talking about.
okay, so the cardio comes from the heart,
Right.
and then the stroke, heart attacks, kidney failures. These are the major organs supplied by the heart. So they are
Right. So heart health, and then of course your circulatory system.
yeah.
Right. That whole system that pumps blood around your body.
Yes,
Okay. It's a
yeah.
major system.
Yeah.
Right. And you're saying that in the geriatric.
Pharmaceutical issues.
Okay.
Because these things are multifactorial, usually they'll take drugs for hypertension, for diabetes, for cholesterol issues, together with other and all that. They are side effects, and they
Right.
need to consciously modulate them.
Okay, let me ask. Legitimately,
Yes.
they've been prescribed.
Yeah.
Okay, so explain to my listener,
Yeah.
when you say polypharm, what is the problem we're talking about? Was a concern about the interactions and the levels of medicines in a person's system. Can you break that down
diabetes and things. And I made mention of the fact that these diseases have multiple etiologies or multiple causes. These causes. And these drugs have toxic profiles. So giving one drug, giving it for us to be conscious about these things. So generally speaking, as we age, we take in more drugs because the issues come or something. You might have dementia or Parkinsonism. You might have eye issues like cataracts and all that, which all these entities require you to take drugs. Would have to depend on to be able to stabilize your system, sort of, to hold these things back. Now, as you take these drugs can
be more good than harm.
Exactly.
Okay. If you've just joined us, it's 34 minutes past the hour of 2 on Joy 99. That we encounter in this segment or spectrum of healthcare delivery. My doctors are taking us through that one. WhatsApp is 055 11 11 997. Ultimate Health on Joy 99.7 FM, where the Facebook feed, I believe, is active, but may possibly or likely be on audio only due to a challenge we have. Discerning listeners will join us. 030-2221-6541. Ultimate Health on Joy 99.7 FM. We're listing vascular. Right. Somebody may want to ask, is it a cardiovascular disease? Is it an endocrine? What is it?
Yes, it's cardiac diseases, and also in the endocrine area too. Diabetes is a disease resulting from malfunctions of insulin. Insulin is one of the, as we grow, and this results in a persistent rise in blood sugar, and we call this phenomenon diabetes.
Right. Okay. Right. So apart
the elderly, they also begin. The risk factor starts when we are much younger, and they progress. Commonly in the elderly, we have in the mid.
Okay. 37 minutes. Oye, I see your welcome message as usual. Glad to be welcome in your home, Oye, in Afienya care unit located. Which other hospitals in Ghana have a geriatric care unit?
It's based on appointment, so you'll have to come in and then have an appointment before. Like I said earlier on, I know doctors who are in training, so I'm sure pretty soon we would have many more of such clinics.
Okay, so for doctors, persons, and we must meet this demand, this need. Okay, so it's not just about having programs like this. The resource must be there on the ground, and then we must be making the health impact. Dede said, did he just go there? The stress from women is one of the many reasons men die early. Oh, come on, Dede. You see, you are even stressing us on the WhatsApp. Dede, but we won't die. We'll respond. He said, did you just go there? When we're talking about the disparity in numbers, okay? We're trying to give our listeners a sense of the profile of the spectrum we're looking at. Good afternoon, please. Is it advisable to be taking supplements at the age of 60 and above? Supplements,
Yes.
We like supplements and tonics and mujadro and all sorts of things. Do we really need them and at this age?
Yes, we do. So as we grow, the body's ability to make use of vitamins and micronutrients generally declines for various biological reasons. The number of enzymes to process them go down, inherent more nutritional problems, etc., etc. So as we grow, there is a need for us to supplement our diet with certain nutrients. Commonly the B vitamins, and then also vitamin C, folic acid, and things for building up iron reserves, zinc, and all these. They are micronutrient deficiency problems as a result of us not taking enough of these nutrients, and they also present as illness. So it's very important that as we grow, we take supplements.
All right.
Sorry, I just wanted to add this quickly, especially in this age group where they have children or grandchildren who may be living outside. One of the practical, because we are situating this conversation in the context of our country, one of the social context that we have is that they are outside, they hear this supplement is good. Grandchild A buys this supplement from another country, another child buys this. The elderly person, him or herself in this country, is buying another. and for some reason, something that they can take all three at the same time. Supplements are they are, as Dr. Aqua just mentioned, are what they are. They are just supplements. They are supposed to add on to what you're already taking.
Right.
So you just have to know the composition, because he also mentioned something about polypharmacy. So the fact that you are taking more supplements in itself doesn't necessarily mean that you are doing well.
Right.
For any reason, that's why we run the geriatric clinics and have this care, because sometimes you can have a particular supplement that tends to have almost all the composition that you need, rather than take one that is maybe for iron, another for calcium, another for magnesium, vitamin D, which are all very essential. So you can go to the market and find one that would contain an appreciable amount of these nutrients, and can be a single pill as well, so that you lessen the pill burden in this group.
Right. Yes. Okay. And talking of pill burden, and I know at that age, remembering your medicines, remembering the name of medicines, having a pill dispensing tray, which is labeled by day, sometimes even by hour and time, helps, right? In other parts of the world, I know there's a lot of concern about even the containers the medicine is in for the elderly, right? So there are certain types of bottles they can't open or have a difficulty with. There are certain types of pill pouches and so on and so forth. Are we that should I say vigilant in our part of the world? Because I know in other parts of the world these are things that you look out for, and you make sure. Especially we tend to think in our part of the world that the elderly would not be living on their own, but they very often have to contend with these medicine taking requirements on their own. Are we that fastidious about these things?
Yes, there's a phenomenon that's well documented.
Right.
Yes. However, in our context, we don't have that. We call it the black polythene, like he said. So when you ask them, please, did you bring your medications along?
Right.
Then they just pull their bag, black polythene with all the medication that they've taken over ages. So it's one of the things that we do in the clinics to make sure that they bring their medication, because over time, as has been said early on, maybe they may have been on one particular antihypertensive or medication to control their blood pressure, and then it wasn't working and it was changed by another doctor. And maybe if the explanation doesn't go well, they tend to take all of these together. So one of the very first things that is done in the clinic is that, Madam, sir, please, did you bring any medication? Then they pull out their polythene bag. If only you ask them, because before you even try and write a painkiller, you'll be surprised how many painkillers that they are taking all together. So it's one very key thing that we do, which here we call it the black polythene.
Right. Okay. I tend to ask them if they can. Many are quite comfortable on social media. Take a picture of all your medications and send to me. Then I'm able to actually ask, but when did you start taking this one? I'm not aware of this one. Oh, my nephew brought me this, or a neighbor brought this. This is a ginseng, this is a that. And at this age group as well, or in this age group, this is something we need to be aware of, even though the younger people also do this, right? It's important that we manage their management of their medicines and make sure that they are able to do that. In other parts of the world, I know that they sometimes find with the elderly and maybe the less educated, the need to tie drug taking regimens or times to times of the day and activities in the day to help them remember. Right.
And also pill minders. These are plastic containers with days and times for each drugs written clearly on them, so it makes it easy for them to follow. These are readily available in almost all our big pharmacy shops.
Right. So use these, and those who are competent and conversant, there are apps on your phone that also help you to manage your medications. All right. So typically, this question also comes up. If I am in the age category we're talking about, I don't really think I have any health issues. Do I need any routine assessment review? I think I'm fine, all right? We know in our part of the world there are people who don't know their numbers, they don't know their blood pressure, they don't check sugar, and so on and so forth. But I'm generally fine, and I think I look and feel okay. I'm listening to you right now. Should I head to some facility and ask for the geriatric unit and have an assessment?
Yes, certainly, because the assessment of this group is comprehensive. Like I said earlier, it's not just about your, your physical parameters. Even if you checked your blood pressure, you checked your weight, you checked your blood sugar, there are things like function, which may look simple. For instance, are you able to answer your phone? Or do you have to tell somebody to make calls for you?
Okay.
That may be simple in the eyes of many people, but in terms of functionality, it points to the fact that you have a certain limitation.
Right.
The other side have to do with maybe your vision. So you may not be wearing glasses, or you may not even have an issue seeing entirely, but you realize that you are falling every now and then. So those are the tiny bits that makes it important for a comprehensive geriatric assessment to be done, because it is not just the physical component, it comprises your whole being. And perhaps maybe you are fine, but you are just feeling lonely at home, and that's a cause of worry for us
so
in the
there's a
geriatric
whole, or should I say, a 360-degree assessment that is done for the elderly person.
Yes.
To make sure that you're looking at their social circumstances, their psychological adjustment, right?
Yes.
Other things, even finances sometimes come in, right?
Yes.
Because you may do an assessment, and because of the financial requirement, that's the last time you're going to see this person.
Yeah.
So all these go into a full geriatric assessment.
Yes.
Yeah?
Yes.
Okay. I can see Dede typing in Maryland there. Phone lines are active: 0302-216-541. Ultimate Health on Joy 99.7 FM. WhatsApp is 055 11 11 997. We're looking at geriatric medicine, and we're tiptoeing into the issues and some of the common presentations as well, with Doctors Ernest Enimopare and Dr. George Aqua. George Aqua is a resident in community health or community medicine. Community
Same thing.
Yeah, same thing, right? Kolebu Teaching Hospital. And Ernest Enimopare is a specialist family physician with the Kolebu Polyclinic Family Medicine Department. If you have any questions, concerns, I've got them locked down here in Kokomemle. You can call right now and they will have to answer you. Right. So these are important things we need to know. And typically at a geriatric clinic, let me ask this before I ask what I'm going to ask. If you go to a health facility and there is no such department or unit, can the average GP or doctor, physician see you?
Yes. Geriatric care is an essential part of general care. So every doctor, every physician in training is taken through not necessarily geriatrics, but all the problems the elderly will encounter. So they have enough competence, enough knowledge to address geriatric issues.
Okay.
Yes. So they can give you preventive care as well as treatment of their issues too as well.
Right.
To include rehabilitation services and all that.
Okay.
Yeah.
Right. So would that mean then, right?
Yes, sir.
Taking into cognizance your earlier definition and the characteristics of this area, which says that one-stop shop, we're not going to have you queuing all day long and all that. Does that mean that if you're seeing somebody within the general system, then despite your age, you will be going through the queues and the long waitings and the referrals and so on and so forth?
Yes. With regards to the queues and the referrals, it's got to do with how our systems are structured. So ideally, the elderly should be prioritized because their tolerance or threshold for stress is much lower. And for instance, if you have an elderly person in the queue waiting to get his blood sugar checked, chances are that he might tip into hypo, and that could be something else, whilst the younger people will be strong enough to stand that. So it's imperative that we prioritize the elderly people.
Let me push you to the wall. Right? Okay, let me push you, George.
Yes,
Dr. George Aqua, to the wall. When we say prioritize, it sounds nice, it sounds lovely.
Yeah.
How do we operationalize that? What does it mean in a clinic setting?
Yeah.
Right? Does it mean somebody comes and looks around or looks at the folders and, stacks those with higher ages on top so that they'll be seen? What does it properly mean? How do we operationalize this?
Yes, for this to be operationalized.
Because I'm looking at a situation where folks listen to us, right? Thankfully, they listen to us. But they go and say, hey, I listened to Nortey and the doctors yesterday. You are supposed to see to me first, right? How does it work?
So, first of all, we need policies from upstream. Yes, sir.
So they are absent.
These policies are, I would say they are not clear cut.
Okay. This is why I pushed you to the wall, okay? So that we know that I go to Kolebu, what George says is, okay, I won't use that word, but it doesn't happen.
Yeah.
Right? How do you translate this to daily care for this category of people?
Yes, the policies should spell out prioritize care for the elderly.
Okay.
That's the first thing. And then two, at the patient's end, patients should proactively demand that my 95-year-old grandmother or grandfather is quite frail. So could we see him or her before seeing the much younger people? And then the practitioners too must buy into the idea and then be able to help these policies to roll out smoothly.
All right, phone line still active, 030-221-6541. I push them to the wall, but I know you guys do it better. So you can call. Dede says, don't some of the medicines, such as those for cholesterol, contain vitamin C, such that taking supplements increases the dose for the daily intake? This is why I think Dr. Nimo Pari was saying we need to know what you're taking, the constituents of the supplements and so on and so forth, and help you streamline, and maybe even dump a lot of them that you may not need, so that you don't have duplications and overdoses and the resultant complications. She's still typing. Okay, that's Dede, right? Dede, when you get to 60, I'll see how you type. Are you 60 or not? I don't know. All right. Okay. So we talked about diet and we talked about supplements. All right. Many people feel, and especially in this age group, that the fact that I'm taking supplements, I'm okay, and therefore they rather compromise their diet, their primary nutrition, right? They're not eating that well, but they think they can make up for it with these supplements, which are widely available and accessible. I'm asking about that, and I'm also asking, sometimes we get cases in the geriatric realm where nutrition is compromised. I think Dr. Enimopari mentioned it, based on dentition. I've lost some teeth, I have challenges chewing, and so on and so forth. So I'm not eating that well. How do we balance these? Because many people feel the solution is the supplements.
Yeah, so with regards to the supplements, we've already iterated the fact that we are taking it not because you necessarily need so much, but because your body has lost the ability to tap into food.
Okay.
So first of all, you're not able to chew properly because of dental issues. Dentulism, a phenomenon whereby you lose teeth as you grow, and you can't do much about that. Secondly, the slow transit time of food, low level of enzymes to process it, and all that. So it's important that you take these supplements so that they can hit the bloodstream and then make up for the deficit.
Okay. Right. All right. That's important for you to understand. Did they ask? Okay, well, we've dealt with that. Right. So mobility, right? We talked about falls, but there are many of these people who can't move like they used to move, right? Is this an issue, and how is this addressed? Is it part of an assessment?
Yes, so there are several modalities for assessing mobility in the elderly.
Okay.
So some of the modalities include a test called timed up and go, in which case the patient is made to sit and then walks for 3 meters and then turns around. The person is supposed to make all of that movement in a straight line without bending so much in about 20 or so seconds. If the duration is exceeded, it's an indicator that the person's mobility is impaired in a way.
Right.
And there are other things that will tell us that a person has impaired mobility.
Okay.
And that's why in a typical geriatric clinic, it's not just about the physician. It's also about having the physiotherapist in there, occupational health therapist in there, having a social worker.
Right.
Because sometimes it could be some other thing other than the the musculoskeletal in itself. So
Okay.
it's one assessment parameter that we do. That's why we think that even if you think you are fit, it's good to have a thorough assessment in the geriatric clinic.
Okay, so we can actually have you assessed, and we look at your mobility, right? Your ability to independently move around, all right? And there are ranges or norms that would indicate whether you are okay or you are compromised
Yes.
in that regard.
Yes.
And then the necessary interventions can be, should I say, indicated and undertaken. So it's very important, right? Can I go up the stairs? If I don't have stairs, can I move around in my social space, and so on and so forth, right? And you mentioned assessment of vision as well earlier.
Yes. Yes. So mobility is it's a function of a lot of things. So apart from the musculoskeletal, of course, the vision. So if the person is not seeing well, they are likelihood to move out of wherever they are because of a certain apprehension to fall.
Okay.
Or if they have impaired hearing, if something drops on the ground and they cannot easily find their way out, all of that can impose. And of course, the other reasons why they may not move, because they may have things like vertigo, which is a form of dizziness. So it's a complete thing that when you are doing, you are looking at other variables that could factor into a person's impaired ability to mobilize from one point to the other.
Okay. Right. My ability to cut this into segments for future programs is not impaired, right? And I'm looking at the clock while saying that. But it's important. So I'm just going to ask this as we wrap up for today. We'll look at other slices of geriatric medicine in the weeks to come. But are you able to do all this? I know when we talk of the discipline, right? The know-how, right? The skills are there. But I'm looking at a typical consulting room in Kolebu and elsewhere. I'm looking at Ernest asking somebody to get up and walk and go and come. And then he'll be assessing mobility. Let's speak to the real facts, because sometimes the policymakers they frustrate us. But in reality, do you have the space within these specialized units, few as they may be, right, to do all these things that we're talking about? Sounds lovely to my listeners. But really, I mean, you're going to ask my mom to get up, take a walk, take a stroll, do this, do that. Then you bring in an OT. Then you bring in this person. The social welfare comes in. Are you able to do that?
Thankfully, in Kolebu, we're able to do that. We have a consortium that gives us the opportunity to do that. And that's why I said earlier that we run a scheduled system, because, the assessment is quite comprehensive. Okay. So if you're going to take about a little over an hour to see a patient who is just enrolled in the clinic,
right,
there's so much, there aren't so many patients you can see.
Right.
So it is possible.
Is it by appointment? Can I just walk in?
So you can walk in. If the main thing is that it shouldn't be an emergency. Right. It should be somebody who maybe doesn't have any medical difficulty. If there is any such difficulty, then the person will go through our emergency triaging system. Okay. But if the person has been seen and is stable, sometimes you refer patients to the geriatric clinic, even within the polyclinic, which means that the person is okay and is now going to be assessed thoroughly. So because of what you just mentioned about the space and time, obviously you can't see everybody. So even though you'd love many people to come to us, I must say that it's not going to be a situation where you just walk in and you are seen, because people would have booked ahead of time just to make sure that
so
they are
you can book.
Yes,
and
you can
should book.
Yes,
and you will be booked.
Yes, you will be booked.
All right.
So there's a particular number of people that are seen on a particular day. Yes.
Otherwise, there'll be a flood of patients and will compromise your mobility. Right. Almost a minute left. Just about a minute left. We'll have to take our time to look at some of these things. By all means, Ultimate Health does diabetes, cardiovascular diseases, and so on and so forth. But I want us to make some time to dedicate time for these conditions as they present in the elderly, and look at the way they are managed typically in our healthcare setting. I don't know whether there's anything you want to add, George, before we leave.
Okay, so one common problem among the elderly men too is erectile dysfunction, and thankfully there are various treatment modalities available.
Can't they just resign, retire?
It's a bit difficult for the men to retire, but then we can help them as they are growing.
Okay. I thought a psychologist could convince them that, right? But it's a big problem. I understand. So you look at some of these things as well.
Yes.
I guess that's why, a pharmaceutical giant will get up and create something like Viagra and all these kinds of things, right?
Yeah.
So you may have a weak heart, but down there you are strong. We need to balance the two, because some people take these Viagras and other things. I'm sorry I'm mentioning a brand name, okay, but there are several now. And then they pop up because they put pressure on their heart.
Yeah.
Okay, so we'll need to talk about those for the men, right?
Sure.
It was Dr. Aqua who brought that up. It's an area of concern for him. Nortey, kindly ask your guest to advise what diet increases libido. I am 45 and gradually losing it. Okay, then you need a full assessment and not just diet. Okay, because you're doing, probably there's other things. Sometimes if you're saying loss of libido or erectile dysfunction or challenges, what we call impotence, not infertility, then you may also have other conditions playing around in there. So it's not just your diet. I'm sure if you get the chance, you'll take something to have 10 minutes of glory, but there may be some underlying causes. Or my docs.
Yes, so
certainly
45.
So I mean, libido has a lot of, it's part of a spectrum of sexual dysfunction. So it could be psychological, and the thing about the psychological bit is that it's a cyclical way where the anxiety of having low libido feeds into not performing or having erectile dysfunction. So the moment you even think about it, you are discouraged because you think you are not going to perform.
Okay.
And then there could be other medical conditions that you mentioned, hypertension, diabetes.
All righty. We've actually done 2 minutes past 3 o'clock. We have to wrap up. Is it advisable to add apple cider vinegar to one's diet? My mom was a strong proponent for this because it helps in your sugar levels, pressure, digestion, etc. She'd also read so many books on this, right? Any comments, or we leave that?
I don't know about how cider vinegar can regulate the role it plays in blood sugar regulation. It could just be a supplementary one, but for blood sugar control, you need to take your diabetes medicines, and they must be monitored and supervised in clinic. Yes, all these other cider things are all supplements.
Great stuff. Many thanks, Dr. George Aqua, community health resident or community medicine resident, Kolebu Teaching Hospital, and Reverend Dr. Ernest Enim Opare, Osofo, and specialist in family medicine at the Kolebu Polyclinic. We'll have you guys in again next week and break down some of these issues. Many thanks to my discerning listeners. Produced by Abeku San Kofi. Stick and stay on Joy 99.7.